It's a lot different than the old days of crown preps and filling placements where once you learn how to do that, that's what you do day in and day out. I think when we get involved with the larger cases and with digital workflow, our mind's always thinking of how can we accomplish this? How can we accomplish more accurately? How can we do it better? How can we collaborate better, give more information to our labs? And I think this is all that in a great way that our digital workflows have been able to help us. Guiding our implants lets us plan for ideal placement in a prosthetically driven implant placement that's going to be ideal for our final prosthesis. It's going to improve our accuracy. All of our goal is to kind of do as much as we can to preserve in our prosthetic techniques to decrease any of that peri-implantitis tissue disturbances. So one of the ways we could do that was the flapless minimal flap surgery, minimal abutment changes or no abutment change.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, episode number 348. I'm your host, Andrew Johnston, and thank you for listening. We have a special show for you today in partnership with DEXIS Imaging, and it's featuring Dr. Robert Pauley as he gives a course on intraoral scanners and how it's, again, hygienists, I'm so sorry this isn't necessarily for you, but it's how can intraoral scanners impact prosthetic design and increase collaboration with the dental lab techs. And also there's going to be some limitations here because some of the things aren't going to translate. As he's giving this lecture, he's giving this course, he will probably be referring to some images that you will not be able to see. And so it's going to be just a little bit different. We're going to try and edit some of those parts out, and so it won't hopefully feel too crazy, but just know that this is coming from a bigger lecture that he's giving. Additionally, some of the topics that are chosen for this episode, but also upcoming episodes, are not necessarily dental hygiene specific. I think one of the important aspects to being content and happy in life is understanding where others are coming from. And so I'm trying to bring you things that might help you understand the bigger process so that your communication with others or their communication to you might be a little bit more smooth. And I'm hoping this workflow is just going to really help you and your teams. And then next week, we welcome the course from Dr. Chris Salerno about managing profit in the dental practices. And we've actually had him on the show before. He's always very well spoken, beloved by hygienists everywhere. So even if his content, again, about the profit isn't what you're looking for when you come to A Tale of Two Hygienists, I think you're still going to really enjoy his words just because he delivers it so well. And I know this month is going to be different. I mentioned that already, but I'm really excited to be able to bring you good, solid CE courses. And because of the way the partnership is working, and I'm not actually going to be on any of the shows, doing the interview part and things like that, we have a very short turnaround time from when they air the courses to when we put it on A Tale of Two Hygienists. So because of that, the links for the CE might not be completely ready as soon as you are. So if you are listening to this the day that they're dropping or the day that they release, give it a few days and check back on our website, and you'll see the links for it. Or you can always email us, Andrew@A-Tale-of-Two-Hygienist, or admin@A-Tale-of-Two-Hygienist. And if you would prefer to see these courses live, be sure to head over to DEXIS.com and see the full lineup for all of the courses that they'll be having this full month of DEXIS Days. So that's it from me. Thank you so much for listening. Enjoy this episode with Dr. Robert Pauley.
A tale of two hygienists.
Hey friends, quick pause in the show to remind you about the CE offered for several of our episodes. All you have to do is click into the show notes and follow the link to the CE Zoom website. Answer a few of those questions about the episode correctly and you'll be rewarded the appropriate amount of CEUs. This wouldn't be possible without a partnership with our friends at TempStars. TempStars is more than just a temp and a placement service. They are clinician-led and education-focused and strive to perfectly match individuals and dental offices. Learn more about tempstars.com or go back and listen to some of their tip episodes. They are absolutely worth the listen. And now, back to the show.
Welcome, everyone. Looking forward to the next 45 minutes to discuss my digital workflow. It's an everyday digital workflow that we use both in my office for implantology as well as, just simple crown and bridge. Just to give you a short idea of who I am, I've been practicing in the Atlanta area for 34 years. About 15 years ago, I've been lucky enough to get more involved in the digital arena and just love that. I find that it's invigorated me in my practice. Every day you can find a new use almost for a digital workflow. It's a lot different than the old days of crown preps and filling placements where once you learn how to do that, that's what you do day in and day out. I think when we get involved with the larger cases and with digital workflow, our mind's always thinking of how can we accomplish this? How can we accomplish more accurately? How can we do it better? How can we collaborate better, give more information to our labs? And I think this is all that's in a great way that our digital workflows have been able to help us. So let's just get started and rock and roll. So when we talk about digital dentistry and partnering in digital dentistry, if you look in the middle would be a circle, but we'll leave that patient's picture out of it. But obviously that's where it all begins. And digital dentistry really allows us sometimes to get the patient really involved because they get to either see it real time as we're planning or discussing or reviewing their data. And as well, from some of the data sets, we're able to make models and have things that they can hold in their hand and really become involved in their treatment planning process. So surrounded by the patient, we have the CT that we'll take on patients, and then we'll move as well as also we'll take an intraoral scan. This is a type of case that we'll talk about later where the gentleman had some injury to the two centrals. From those, we will merge those into DTX where we can start our planning process. And then you see from the intraoral scan, the CS3800 wireless in this case, we're able to send those files to the lab to have an immediate provisional made, and then turn around and utilize our dynamic navigation with X-Guide to dynamically navigate and place our implants. This is a great book here for reference. It's by a couple of good friends and mentors of mine, Dr. Rinaldi and Gans, as well as Dr. Mottola. I love Dr. Gans' saying that, there's dangers when we're bound by two dimensions in a three-dimensional world. And sometimes now they talk about fourth and fifth dimensions, but right now 3 dimensions is about all I can handle. But this is a case I work with a lab technician, Lars Hansen, and it's a case again where we're designing the provisional long before we ever think about placing titanium in a patient's mouth. But with this type of design, we were able to move forward with an immediate provisional where we placed the 6 implants. And we have some tripod effect that we're able to utilize to help us place our immediate provisional in the correct vertical dimension. And as you see, here's some lab work where everything's able to be digitalized, and we can kind of see again where we're having our screw holes emerge. So if we need multi-units or what degree multi-unit, we're able to do all this, at the beginning of our treatment planning. Just like if you were taking a trip this past Labor Day weekend and you were driving somewhere, you don't just get in the car and take off. And anymore, you don't usually get in the car and take off and look at a map. You've probably got some GPS system like Waze to help you, not only if you know the direction already, but to help you if something that comes along the lines that, hey, there's a traffic jam ahead and you need to divert to another route. That's one of the great things about digital dentistry. And the things we'll talk about tonight is it really gives us real-time viewing when we're doing our surgery, and also gives us a great way to practice and set this up. That's another great thing about this textbook. These gentlemen have really discussed in depth their surgical techniques for dental implants and grafting and surgery, either pre or during implant placement. And what they do in the second half of the book is they turn around and list surgeries and walk you through how they used each of those. So it's a great way for you if you have a surgery coming up that you just want to kind of touch up on your techniques. You can look at that and you'll find in that book many examples of the surgery that you're planning on doing. And you get to practice that ahead of time. Our learning objectives tonight is one of the first things we're going to do is talk about how we utilize intraoral scanners. And we've already talked about a little bit about how I'll use it during immediate prosthetic phase design and also to obtain our final impression. And understand the importance of collaboration with your dental lab technicians. Digital dentistry really gives you a great way to get the files, photos, lab prescription, everything to the lab technician pretty much immediately. And then it also lets them have a great way to visualize your preps and what the patient looks like with your intraoral and extraoral photos. We'll discuss the importance of a cosmetic blueprint when we're developing our prosthetic-driven implant plan. A cosmetic blueprint, again, we want to know where we want to be with our final prosthesis before we start thinking about placing implants. We want those implants to be placed as strategically as possible to maximize our success of our surgery and also maximize the outcome of our prosthetics. And also through this, you'll see me noting clinical evidence. So most all of my presentations, I really like to talk about evidence-based data, not just, even though DEXIS is so kind to ask me to talk on their behalf tonight during their DEXIS Days presentations, I want to give you some clinical evidence of the reason I'm using the particular armamentarium and the workflows. Here's a great example. This is a paper that Dr. Alessandro Pozzi put out a few months ago, and it just talks about one of his approaches to single tooth immediately loading an implant. And on the right are pictures of a case that I mentioned earlier. You'll see in the top, the patient was just about nearing retirement, and he was working on a high pressure hose on his truck, and it broke loose and snapped number 9 off and really loosened number 8. So the treatment planning was involved, and we were able to have the lab with the help from the DTX planning files and our X-Guide placement to make us a provisional shell before we have our surgery. We come in and we do the dynamic surgery with X-Guide. So that way we're placing our implants exactly where we planned them. And you can kind of see this is the final in place. We've got really nice keratinized tissue. This case would be 2 single tooth implants. I was a little bit wanted to send it back and darken those a little bit, but the gentleman had no issue on that. He was very pleased. So you'll also see what I do today. It's wet-handed dentistry. Again, like I said, I'm a GP, and so do a little bit of everything, and it's real life. So nothing's been touched up, no photo shopping. Probably wouldn't know how to do that even if I could. Here's the paper going more in depth, and it just talks about the time that he needs to take place in this workflow. And you'll see one of the first things we'll do is take a CBCT. And then he's given a time on that, maybe of 10 minutes, setting all that up. Then an intraoral scanning of the patient's full arch, 5.5 minutes, sometimes longer. Never really worried too much. I don't worry about time. It's just getting it accurately. So just take your time and get it right the first time. Then you generate the virtual patient and digitally assist in the implant planning. That's where you're using your DTX Studio to merge your CBCT and your iOS. Now what we'll do is you can then export that file to software if you have it in your office, and you can go ahead and do your milling there. In my case, I work with Jay, small root lab, and export him my files, and he was able to fabricate the provisional. Once they fabricate that provisional for you, you're also able at that time to then take the STL file that they use for the provisional, and when they send that back to you, you can place that into your surgery and you move right forward with your surgery. And so in this case, they're saying 25 minutes for the surgery, the calibration, the dynamic surgery, and then your 20 minutes for your refinement of your temporary shell, get everything out of occlusion, maybe get them an impression for a night guard, and you're done. Very nice. You'll also see that Dr. Romanos and Mish have talked in the past the advantages of going ahead and having an immediate implant placement, because it's going to give they're finding that the bone was sounder after time. And it also helps hold your grafting material in place, and it helps you maintain the soft tissue in your hard tissue. Here's just a short video of the immediate provisional design from Root. And you'll see this was the CS3800. We took the scan, sent them also the surgery files, and they were able to merge those together, show the virtual implants in place. This gentleman did do me a favor, and you always got to look at your occlusion, but he's got an anterior overjet. So in this case, I was able just to leave the wings in place on his temporary, and I know that he's not be able to push any buccal force on those. With the intraoral scanner, you heard me mention before cosmetic blueprint that coined at Root Dental Lab. Brian Linke here in Atlanta also has virtual emulations. You've heard of Christian Coachman, and John Heimke will lecture about digital smile design. All this is again, you're using your intraoral scanner to help you jump ahead and plan your prosthetic design before you start down the restorative road. With my 3800, and I have used both the 36 and 3700 as well still in my office, we will use these for single unit crowns, multiple unit bridges, single unit implant restorations or bridges, and then natural teeth crowns and implant crowns in combination. Not meaning an implant to a natural tooth crown, but just have cases where someone will be missing a lateral or a central the other day that was knocked out. The oral surgeon was able to extract the root. And then when the patient came to me, we did a cosmetic wax up with the intraoral scan, and we're able to prep the adjacent teeth, and she's able to use those as a temporary while we get ready for the final implant after the bone graft is healed and the implant crown. And then that way we'll work toward a nice final aesthetic look versus just taking the impression and using a quick vacuum former for her temporaries. Again, we're talking about the cosmetic blueprint. So one of the great things is it does give the patient the chance to visualize the treatment plan. They can hold that in their hand when it comes back from the lab, the cast, to look and see. It's not just looking at pictures. I think that's another great utilization of this workflow. As I mentioned, the lab can fabricate the temporary or the provisional shell. On larger cases for like veneers, they can also fabricate a silicone matrix that you can utilize to make your temporaries with. As we mentioned before, the STL files can then be imported back to the DTX studio to plan the final implant placement under that ideal lab fabrication that you've undertaken. And then finally, you can export the surgery directly from the DTX to a thumb drive and then import it into your X-Guide that allows dynamic navigation of the implant. Here's another case where when we're always talking, in dentistry, we're always looking at return of our investment. Here's a case for 3800 where the lady is just finishing ortho. So we took a scan. Root Lab was able to then print her cast, which you see on the upper right. Then we export that scan STL through CS Connect, and then the lab is able to digitally design single unit crowns for the undersized laterals 7 and 10 and place a tooth in number 5 that I'll be able to use for the implant crown. So for this patient's case, we charged $750. We had like 3 teeth that we were having the lab to digitalize and diagnostically work up for us. And you can see in the bottom, now we have the cast that we can show her from the anterior view and also from the occlusal view. And the lab fee comes back and it's like $154. So you see there, it's almost $600 return on your investment for the fees. It's a great way for the patient to see what they can utilize. And now I've got these casts that I can use if I needed to have a temporary splint that I make from these. And I've also got the STL files that I'll be able to move over into my X-Guide to plan the implants to come out these teeth ideally. It will also let me see, okay, if I on the anterior teeth, is there a way for me to be able to direct the implant alignment, as Dr. Gans had mentioned, in the triangle bone? Am I able to have enough triangle bone that I could maybe sneak that implant to come out the lingual, where we can have a screw retained retention on the 7 and 10, which is always nice. We don't have to worry about cement. Or if it does show us that we're going to have to do cement retained crown, then we'll just have the lab design a crown with margins that would be right for that. So with an intraoral scanner, there's always a learning curve. I'll always say, you just need, like you do in a normal polyvinyl, you're going to need good retraction. You got to have discernible margins that if you can't see it, the intraoral scanner can't see it, and your acquisition technique. And finally, I'm going to say it doesn't matter what you're doing. In this case, obviously, we need a dual arch, but you always want to take full arch scans, even on a single crown. The lab is going to do a couple things. One thing is it's going to make your life easy when you come back to seat your crown, because it's so much more accurate. There's minimal mesial or distal interproximal reduction and minimal occlusal reduction if you nailed your bite registration. So just take your time, take your full arches, and make sure you get a nice bite registration. Here's an article by Dr. Lee and all that discusses the use of an intraoral scanner during the prosthetic phase of implant dentistry. And they show that by using the scanner, you're going to eliminate potential errors during acquisition. You have real-time viewing. So, I took polyvinyl impressions for years and got to the point where I was fairly good at it. But, you still got that 5 minutes that you're waiting for everything that's set. And if you had an issue with it or a tear, you got to come back and reimpress. Here, if you don't like the margin that you're seeing, if your cord has moved up over your margin, it's very easy just to go back and cut the data out, and at that time just rescan it and you're off and running. So it's going to save you some money by eliminating impression material or reducing the amount of impression material you use, bite registration materials, and also stock trays. And then finally, again, as I mentioned before, it decreases chairside working time. And I'll take a moment here just to mention too how important it is for your staff to get involved. My staff can scan as well or better than I can. So what that does, it allows me to come in, see a patient, check and make sure I have the radiographs and such that we need, anesthetize the patient, and then leave. They'll get an impression for that arch for the temporary, and then they'll take a full arch scan for me. Here's another chance that if you'd had a scan on a patient before and you're doing another crown prep, you don't have to take a whole new scan. You just have to come back and rescan the crown area that you maybe have restored in the past, and then you're just working with today's scan. I come back after they have got the intraoral scan and the impression, do my crown prep. I'm off again to check hygiene or see another patient while the pack cord, and then I come back and finally I'll just take the quick final impression and I'm out again while they make the temporary. And then, like I said, on the return aspect, it seems to be so much quicker as well, seating those with very minimal adjustment. The 37 and 3800, as well as the scan flow software, which is what runs it all, and it's really, really robust. But each time that we've had new developments of software, it's just helped things get quicker. So we got a nice quick capture speed, a really nice cleanup of non-essential data. So when you catch your purple latex glove, as soon as you stop your scan, it'll most of the time will remove that quickly. You won't have to cut that like you did at the beginning. These two models have shade selection and shade report, so it's nice to send those as well to your lab. And they have intuitive workflows. So we got a scan body workflow in the implant arena. We've got an impression for a hybrid workflow, meaning if you're taking on one of your adjacent crowns, maybe it was a deep margin, and you're worried about being able to see that with the scanner, you're able to take the impression and scan that impression and push it into digital workflow. And again, like I said before, you got pre and post scan capabilities. So if you've done a large case where, as we mentioned earlier, maybe we've done 6 anterior crowns with 1 implant to final impression, we're able to go ahead and scan that temporary provisional that we've had designed earlier and show that again to the lab, that they can look at that. And if the patient had any kind of tweaks or changes they'd like to have, it's really easy for us to collaborate that and tell our lab technicians what we'd like to have done for any adjustments on the finals. With the scan flow software, as again, we mentioned CS Connect. It will soon be called DEXIS Connect, I'm told. But this is just a quick way for you to immediately move this STL data from your computer to the lab. And when you do this, you can incorporate any digital photos you want to send, extra oral photos, photos of the patient smiling. All that can help your lab with your final prosthesis. And again, you can export that to a thumb drive if you wanted to send for some other lab. Maybe it's not on your CS Connect. You can import a new scan. So as mentioned earlier, if you're working on a patient that you've just had a crown prep on the other side, it saves you time by importing that new scan. Or as I'll show you later, if you've done a scan for someone for ortho for an Invisalign case and they end up having a tooth extracted, you've got that model of a tooth that they've had for 70 years in their mouth that you're able to design the final crown for, not just one you had to wax up. And you're able to do these in restorative and implant workflows and orthodontic workflows. Here's just a quick little workflow showing the capture of premolar prep. It'll give you some ideas you see with the green arrows that they may want you to run back over and catch another spot. Here's the bite registration. They average the bite registrations to get your final bite when you send to the lab. I usually like to keep taking the bite registration. I only send one. I send the one that I usually like to take. And I'll keep taking till I get exactly what I want. So you just have to take your time and look at those, but you'll find your workflow as you move along. Dr. Robert Emery is another mentor of mine. He has coined the phrase pretty much in his case, it's every patient, every implant, every time. And one of the questions might be, why would we navigate? So navigation gives us the accuracy of static guides, but solves all the challenges associated with those. So possible movement, having to reflect a larger flap, or confined space. And your accuracy in microns is much better with navigation, and it gives you the flexibility of freehand. So you can change while you're still moving, and you have the flexibility of freehand. You have the less confined spaces, but you're still going to have that wonderful accuracy. Here's a great paper by Dr. Michael Block, and I'll mention showing how your angular deviation is always better with guided versus freehand. And in this particular case, is one of my cases, you're able to watch your bullseye. For those of you who've seen X-Guide in some shows, but and played around with it, but you're able to watch your navigation. You will go around that clock, and pretty much every time it gets to 9 o'clock, that'll be your finish line. If it's a 10-degree implant or a 15-degree implant, it'll always finish there. In the screen next to that, you'll have 3 different views also to watch to show you how your burr is being guided. And you notice here, it's kind of hard to see, but below that, you can see it really at a depth of 10.6 millimeters, our degree of deviation is only half a degree off. So I'll take that every day. Another article by Dr. Emery, and I'll mention why would you do not dynamic versus freehand? And one of the cool things that it mentions is, now our patients are really educated. They're really coming into the office and they've already heard about implants, and they've got the idea of what they may want or their goals. And so they're really aesthetically and hygienically driven now. So guiding our implants lets us plan for ideal placement in a prosthetically driven implant placement that's going to be ideal for our final prosthesis. It's going to improve our accuracy. And one of the big things it's done for me in the last 6 years, I think, since I've had X-Guide, is just let me know with confidence that I'm going to place that implant where we planned it. Here's the gentleman we talked about earlier. He had the 2 teeth that were damaged in the accident. You see here we are kind of close confines with a really large incisive canal. So we've got these planned in such a way that we can avoid the canal. We're using our paralleling tools to kind of help us with virtual implant placement that's going to really make it easy for us to line these in a way that we can draw on that provisional. You can see here that we did not have to do any flat elevation. We went pretty much straight into the socket. So that's not going to have any disruption of our blood flow. And again, we can have real-time surgical modifications if we need. Just for any of you all that may not be familiar, this is just how we locate our patient. In this particular case, when they have teeth, we can use a little patient tracker that has 3 little fiduciary or BB-like settings in this tracker, which is then attached to the patient tracker arm. And this lets the computers and the cameras see where our patient is at all times. This is the lab fabricated temporary that came from Root Dental Lab. So you see we've got the shell of the crown. I went ahead and then placed the abutments and then was able to try in a couple of times and have a nice root emergence profile. And so what you're seeing here is like the day after patient comes back on the surgery, and from us not bothering anything with the flap, you can't really tell he's had any implants other than the fact that we made these temporaries really, a lot shorter than his teeth next to it. So it would be any chance of him hitting those or disrupting in lateral occlusion. And there you see, again, we showed a while ago, there's his final. So we've been able to maintain the nice, healthy gingiva. We got great stippling, and he's just overly excited. I'm going to show you a case now. We'll talk about, this is kind of like one of my go-to treatment plans when we're talking about PDIP. If you've got an intraoral scan and you start using your camera and take these on every patient, pretty much if you're going to do any comprehensive work, then pre-extraction, if you've got a full mouth, you're able to take the intraoral scan prior to your extraction. It's going to give you a sense of both arches when your planned crown implant is placed. But you can base that again on a tooth that's been there in the patient's mouth before. This scan can be exported to DTX Studio Implant during the treatment planning phase, and we'll plan it. And then afterwards, we'll be able to move it over to our dynamic navigation with the ideal alignment and orientation of the original crown. So 3 months later, CBCT will take a pre-extraction CBCT. Post-graft, maybe 4 months later, we'll take our final. We can export this to DTX and XNAV and dynamically guide the implant planning and navigation. So in this particular case, a friend of mine was skiing in Telluride, had an issue with number 19, and had the tooth extracted while he was there. The dentist did a great job, did a nice socket preservation, and the patient comes back to me in March, and we were wanting to take a CBCT and see how it's healed. The cool thing in this case was we had a scan that was left over from when we did Invisalign a couple of years back, intraoral scan. So when we come back in here, we can plan this. We're going to be able to plan it to his crown that was there originally. There's no way any of us would be keeping stone models from 3 or 4 years ago from ortho or a comprehensive case. So that's another great area where we can store this data and get to it at a later time. So we do our preliminary 3D treatment planning. In this case, I think it's a 5.0 by 13.5 Nobel Active that we're planning in site number 19. We push this over to DTX Studio. We're also able to push in his original intraoral scan. So you see now we have a tooth again in number 19 that was there before. So we're planning this. The cool thing I love about these implants, this is it was a parallel CC that I've treatment planned with the TI Ultra. So they're showing that there may be some help with that with the bone osseointegrating with the surface. But I love these on-one abutments with the seal surface. I pretty much put those in all of my posterior implants, because what you're doing here is you're only placing one implant and you're placing one abutment on that implant, and everything else you're going to do is going to take place, if at all possible, 2.5, in this case, 2.5 millimeters above the abutment implant interface. So you see here, you can see a little bit of soft tissue that I'm still at or a little bit below the soft tissue area of my finish line, but I'm never going to come back down here and damage any of this by taking the screws off, which a lot of times studies have shown there'd be maybe 5 times that you would disrupt that healing implant interface with healing head or second surgery or your provisionals. So we're going to try not to ever disturb that. And we can easily plan that with DTX. So now that we moved it over to our X guide, you can see again that the ACL files have let us be able to move over an intraoral scan. We're able to plan this again and tweak it again and make sure everything looks reasonable. But we see where we've got the implant pretty much coming out of the central fossa of the tooth correctly in the mesial distal location. And this is a 5.0 by 11 implant that we're planning. Now what we do is we'll utilize X guide and X mark to calibrate for surgery. We pick 3 spots on a patient's rendering, and then we'll pick 3 spots in their mouth and calibrate those. And you'll notice that we want a nice spread quality over 11. We're great. And in any of these numbers here need to be under 1 millimeter. If not, we just go back and check again. But in this case, we're able to go straight to surgery. Here again, you're seeing what I'm talking about with the bullseye. You just kind of keep everything centered. There's your dot. Here's your second circle where your implant radius is. And again, this is your depth gauge. It goes yellow all the way to 1 millimeter from the final, and it'll start turning green. And if you were to go over, and when it gets to the end, you'll hear an audible beep. If you're able to go over a little bit, you'll see it in red. It's pretty cool. You can see we're pretty much dead on here with both our osteotomy, mesial distally, and cross section, but also we can see where we've had our nerve incorporated there as well. So very happy that in this case, again, we're half a degree off at 10.5 millimeters. Just shows you real quickly the parallel CC where you dripped it in a little PRF. There's the on-one abutment with the zeal. Again, we want this 2.5 millimeters in height. Studies are showing us that if we can keep these abutment crown interfaces at least 2.5 millimeters or more above where our implant placement is, that's really giving our biologic width to our soft tissue and having less chance of bone dieback. There's the zeal placed. You can see what I mentioned before, it's right at or just a little below the soft tissue level. We had nice osteo readings of 68 buccal lingual and 65 mesial distal, so we felt comfortable in placing an implant in the site. This is another thing where you just know your patient selection. I know this person, I know they'll follow my directions as far as dietary needs and such. They live here in Atlanta, so it'd be very easy if you needed to come see me. So didn't have any issue placing an immediate provisional on this side as well. Here's another short video that's going to show the lab fabrication of the shell for this one as well. You can see They've utilized ExoCAD, and they will design this temporary from the surgical files that I have sent. The wings are on adjacent teeth just to help with seating of the shell over the abutment temporary plan. Now, DTX Studio, it does have Nobel as well. There are other implants in their catalog, and they have the on-one abutment and then the on-one abutment with different height screw retained provisional. So it's easy to pick all of that out of your catalog as your treatment planning. So here is a screw retained temporary coping for an on-one seated. We'll need to relieve that a little bit. Here's our lab fabricated temporary shell. All we do, you see, is relieve the temporary out of the mouth, reseat it, place a little silicone over the hole, and just try in our provisional, make sure it seats nicely. In this case, they did a wonderful job. I just had to relieve a little bit on the distal just to make sure I had enough room for the pickup material. And then we just pick it up and we retrieve it. And the on-ones are really cool because there's not a whole lot of subgingival material that you've expressed. So the lab has pretty much done your root emergence profile for you. So we just take it out, take the wings off, check to make sure it's not inclusion, and do our final polish. So there's our final temporary. Flow a little flowable composite in, and we're done. Now we go back to our question earlier, why navigate? And from that article, Dr. Block, I showed you, you can see right here, in some cases when you're first starting with your X-Guide and you're wondering how accurate you are, or you want to see your accuracy, this is what that you can send them back at the CBCT post-op, and they can transpose your actual implant crown over where your implant was placed. And you can see we're pretty much dead on here. Probably just a little bit knocked off here, just a little bit from that dense cortical lingual plate. But all in all, very, very happy with the accuracy. And they could also tell by the way, there was hardly any adjustment needed for a temporary. Here's the post-op limited field, another view that you can see. And in this case, I just kind of wanted to show you that this is the implant. And in the middle here is your on-one abutment. So this is torqued to 35 Newton centimeters at the date of the implant surgery. And now all this from now on takes place up here, right at or below the gum level. And so you're not disturbing your implant abutment interface at the bone level. 5 days post-op, you can see we've got it nicely out of occlusion, but he does have, a nice temporary that's holding in the bone graft material. We've got nice, healthy looking muco integration. He's very pleased to have a temporary there. And we're happy to see that there's hardly any wound because we don't have to reflect the flap to visualize during the surgery. Again, this is just the occlusal views of the occlusal and lingual views 5 days post-op. Here we use the intraoral scan again. Now we're ready to take our impression. So you can see it moves fairly quickly. This obviously is edited and speed and has speed. It takes out some stationary time, but really truthfully, it goes very nicely. Great pickup. You saw a glove capture there would be taken out. First thing you do on the implant workflow is you're capturing, this would be your soft tissue. So there you see that we've taken the temporary off of the on-one abutment and we're scanning that. We'll catch some nice tissue, make sure we have nice mesial and distal interproximal surfaces on those. Here we're trying to capture the full bite. And we noticed the first time I just really didn't like it. You can see it's a little bit open there on the distal. So real quickly, just go back, scan again. And we like that. Next thing we do is move straight forward. When we take the soft tissue, we're going to remove the data that had the soft tissue showing. In that case, you saw the on-one abutment. And now we just put the on-one scan body that also doubles as a healing body. And then that's what we utilize to get our final capture. So again, you want to do a full arch scan. You want to capture some nice soft tissue on either side, get you a good bite registration and capture the scan body. Just a quick flow through. There was the pre-op. There was the day of surgery. After surgery, you see the screw retained provisional, and then there you see the final. And we've preserved the interproximal bone lysine, and the patient has really nice buccal tissue. Where all of our goal is kind of do as much as we can to preserve in our prosthetic techniques to decrease any of that peri-implantitis tissue disturbances. So one of the ways we could do that was the flapless minimal flap surgery. Minimal abutment changes or no abutment changes. That's a nice article by Dr. Dwayne Caretu. And talks about the advantages of that. And again, that was one that I could quote with the number of times you're taking this abutment on and off. One-time abutment, really, really helpful. If at all possible, we want to aim for screw retained prosthetics. But if we can't, with our cement retained prosthetics, again, with our collaboration with the labs, we want to tell them, hey, we want this abutment to be at least 2.5 millimeters with a concave surface. And then we want our crown margins to be, maybe a millimeter, no more than 1.5 millimeters subgingival on the buccal, and, 0.5 millimeter to right at the gum level on the lingual. All this can help you with your removing the cement. Dynamic navigation treatment planning and surgery really helps us with this. I think it starts with your CS Intraoral 3800 or 3700, your intraoral series with your scan flow. You use your DTX to do your treatment planning. And then finally, you're using your X-Guide to do your dynamic placements. So I hope you guys have enjoyed the session tonight. Alyssa and Amy have done a great job putting this together. I really appreciate the invitation. If you ever wanted to learn a little bit more about surgical implant and prosthetic navigation, Dr. John Russo has a great program where he and Dr. Emery will spend a day working us through this issues with single tooth implants, and then we'll go to full arch reconstruction. And then I'll be there with Stephen Balshi, and we'll talk about how we do the full arch, and then have the lab guy technician involved as well. And there's one more session this year. It's in October 21st and 22nd. DEXIS and Nobel both been very kind to help and support this program. Lastly, the Invista Summit, if you all haven't noticed, it's coming up this year in 2023. It'll be in Vegas, the end of February. I had a wonderful time this year. My first experience at the Austin Invista Summit. So again, there's implant workflows or restorative workflows. There's courses for pretty much anything you might need along the comprehensive dentistry or implant workflow lines. So with that, I'll say thanks, y'all, for turning in. Obviously, I can say y'all since I'm living in Atlanta and from Kentucky originally. So you probably heard that in my accent. But special thank you to DEXIS for inviting me. Here's my office address, my email address, and my office and mobile phones. If you have a question or you would like to talk to me, just give me a shout.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.